There's this comforting illusion in medicine that we're always on the verge of finding the clean solution.
The silver bullet.
Exactly. The drug that hits the one right receptor, or the study that just, settles the debate for good. But if you actually read this stuff, really dig in, that clean is a total fantasy.
Oh, it's messy, especially in psychiatry. The biology's messy, the trials are messy, and the decisions we have to make are almost always a trade-off.
A trade-off between two different kinds of risk.
Exactly.
Which is a perfect lead-in to this month's source material.
Yeah.
We are going deep on the February 2026 issue of the Carlott Psychiatry Report. And honestly, this one feels like a masterclass in reading between the lines.
It really is. We're not just looking at what the FDA approved or didn't. We're asking how it got approved and, what the data actually tells us.
So we've got Brexpiprazole's roller coaster of a year.
A big one.
A really challenging interview on perinatal mental health that kind of reframes the whole safety conversation.
I thought that was fantastic.
And then some surprising research updates on everything from service dogs to vitamin D. It's about busting some myths today.
Or at least exercising some critical thinking about how we read the evidence.
Okay, let's jump in with the big headline. Brexpiprazole, which most of you know as Resulti.
Right. It's a third-generation antipsychotic. We've used it for schizophrenia, for depression augmentation for a while.
But the big news is the FDA just gave it the green light for agitation associated with Alzheimer's dementia. And on the surface, that looks like a massive win.
It does. We have been desperate for an on-label treatment for this. Using things like Seroquel or Risperdal off-label is just, it's a legal and ethical minefield.
So this is a landmark approval.
It is. But, and it's a big but, if you look at the actual data that got it there, that victory lap feels a little premature.
Yeah, I was looking into the trial history. It wasn't exactly a slam dunk, was it? The FDA made them do a third trial because the first two didn't beat placebo?
That's exactly right. And that's the kind of detail that gets buried. The drug didn't fail because it was useless. It failed because the placebo effect was just enormous.
Right.
You see this in agitation studies. The caregivers in the placebo group, just by being in a study, they get more attention, more support, and they get better at managing the behaviors.
So for the third trial, they basically had to stack the deck.
They enriched the sample, yeah. They specifically looked for patients with more severe aggressive agitation to try and force a separation from placebo.
And they got it.
Yeah.
But let's talk about how big that signal was. The scale they used, the Cohen-Mansfield, it's a 174-point scale.
Correct.
And for a result to be clinically meaningful, for a family member to actually notice a difference, researchers usually want to see a drop of about 17 points.
Around 17, yes.
Brexpiprazole got a 5-point reduction over placebo.
5 points. Just 5.
So is it statistically significant? Yes.
Yeah.
The p-value is there, but is it clinically significant? That's a tough sell.
It's very debatable. A 5-point change might be completely imperceptible in a chaotic home environment or a busy nursing unit.
And you have to weigh that tiny change against the black box warning. We know these drugs increase mortality in this population. What did the safety data show?
The numbers were pretty consistent with the rest of the class.
Yeah.
It was a 0.9% mortality rate in the drug group versus 0.3% in the placebo group.
So a threefold increase in risk.
It is. Now, they determined the deaths weren't directly from the drug. It was heart attacks, infections, but the signal is there. You're trading a threefold mortality risk for a 5-point agitation drop.
That is a brutal calculus. And just to be clear, this approval is only for agitation, not for the actual psychosis, right? The paranoia, the delusions.
No, and that's a critical distinction. It seems to take the edge off the motor restlessness, the pacing, that kind of thing, but it doesn't seem to touch the delusional thinking.
So that was the win, sort of. Now the loss. The FDA shot it down for PTSD.
They did. They were looking for an indication as a combination therapy with sertraline, and the FDA said no.
And the reason why really gets at a huge flaw in how we run psychiatric trials. I was reading a critique by Dr. Mark Zimmerman.
Yes.
He pointed out that the inclusion criteria for the study were so strict that only about 5% of his real-world PTSD patients would have even qualified.
It's the perfect patient problem. They screen out anyone with substance use, suicidality, instability, which, describes a lot of people with severe PTSD.
But the real kicker, the thing that killed the study, was the withdrawal issue.
Oh, this was a huge confounder. To get into the trial, if you were already on an antidepressant, you had to stop it. Cold.
You had to wash out. So you're taking people who are already struggling, you're putting them into withdrawal, they feel awful.
And then you randomize them. So the group that gets the new drug combo starts to feel better. But are they feeling better because it's treating their PTSD, or are they just recovering from the withdrawal symptoms the study itself created?
You can't tell. It completely muddies the water.
Exactly. The FDA couldn't distinguish the drug's effect from withdrawal relief, so they rejected it. For now, it's out as a first-line combo for PTSD.
But there is this one little interesting piece of basic science in the report. In animal models, right?
Yes, this was fascinating. In animal studies, if they gave Brexpiprazole shortly after a traumatic event, it seemed to prevent the consolidation of that traumatic memory.
So like a morning after pill for trauma.
That's the theoretical idea, yeah.
Yeah.
It suggests that while it might have failed as a chronic treatment, it could have some potential as an acute intervention. So maybe not a dead end for PTSD entirely.
Okay, so let's shift that risk-benefit analysis from the end of life to the very beginning. The interview with Dr. Amritha Bhat on perinatal mental health. For me, this was the highlight of the issue.
I agree.
We spend so much time talking about the potential risks of medication to the fetus and so little time talking about the risk of the alternative.
Dr. Bhat really hammers this point home. She says we're asking the wrong question. It shouldn't be, is this drug safe? It should be, what's the risk of this drug versus the risk of untreated mental illness?
And the risk of untreated illness is huge. High cortisol, poor fetal growth, not to mention a 50 to 75% risk of relapse if a mother stops her antidepressant.
That's the key statistic. It roughly doubles the relapse risk.
Well, let's bust some myths. The big one is autism. We still see headlines linking SSRIs to autism.
And that link has really been debunked by better, more recent studies. The early studies just didn't control for the mother's underlying illness. When you do that, the signal goes away. The consensus now is that the medication does not cause autism.
But there are some real, though manageable risks. She
Yeah.
talks about poor neonatal adaptation.
PNA, yeah. About a quarter of babies exposed to SSRIs will get this. They're jittery, irritable, maybe have some trouble breathing for a little bit.
But it's transient.
It's transient, it's self-limiting, it resolves in a few days. And her point is that a few days of jitteriness is a much better outcome than a mother relapsing into a severe, debilitating depression.
She also had a great take on which drug is safest. We're all taught that it's sertraline Zoloft.
That's the textbook answer because of low placental passage.
But she argues the safest drug is the one that works for that specific patient. If someone's been stable on Prozac for a decade, why would you risk destabilizing them by switching to Zoloft for a tiny theoretical benefit?
Exactly. Keep the mother well. That's the primary goal.
With one major exception, Velpro.
Valproate or Dapaco, that's the hard no. The risk of neural tube defects and long-term cognitive problems is just too high to justify. That's the conversation you have to have, ideally before they even conceive.
I want to dig into postpartum psychosis for a minute. We tend to lump baby blues and postpartum depression together, but she makes it clear that postpartum psychosis is a whole different animal.
It is a psychiatric emergency. The blues are common. They peak around day 4 or 5. They go away. Postpartum psychosis is rare, 1 or 2 per thousand births, but it's terrifying.
And the presentation is more like a delirium, right?
Very much so. Confusion that comes and goes, delusions, often centered on the baby, and it can come on fast.
The numbers are just chilling. A 4% risk of infanticide, a 5% risk of suicide.
Which is why you have to be aggressive. And this is where it connects back to bipolar disorder. Most cases of postpartum psychosis are actually the first manifestation of bipolar disorder.
So for prevention in high-risk women, the go-to is lithium.
Lithium is the gold standard.
But lithium has its own risks. The cardiac risk, Epstein's anomaly.
It does, but we have to be really precise with the numbers here. The baseline risk for that heart defect is about 1 in 20,000. Lithium might increase it to 1 in 1,000.
So the relative risk sounds huge, a 20-fold increase.
But the absolute risk is still tiny. 99.9% of babies exposed will be perfectly fine. And you compare that tiny risk to the near 100% risk of a severe psychotic relapse if a woman with bipolar disorder stops lithium.
When you frame it like that, the choice becomes a lot clearer.
It does.
And there was another intervention she talked about that I think we completely undervalue, sleep.
Yes. For postpartum psychosis, protecting sleep is a medical intervention. It's not just getting some rest.
Sleep deprivation is the #1 trigger for mania.
So she's saying we need to prescribe sleep. Have family take the night shift so mom gets 4 or 5 straight hours. Use a benzo like lorazepam if you have to. It's that critical.
Okay, speaking of new treatments, A quick word on zuranolone.
Right, the first oral drug specifically for postpartum depression.
It's a neurosteroid, works super fast, like within 3 days.
But the big downside is sedation. It's a Schedule IV controlled substance for a reason. It causes profound CNS depression. You take it at night, and you absolutely cannot drive the next day.
Which is a huge logistical challenge for a new mom.
A huge challenge. It's a powerful tool, but probably for more acute, severe cases where you have a lot of support in the home.
All right, let's switch gears to the research roundup. The service dog study really surprised me.
Me too.
Yeah.
We all love the service dog story, right? And it is life-changing for many veterans. This was a proper controlled trial.
And it found that veterans with dogs had lower PTSD symptoms. They stuck with therapy better. All good things.
All good. But here's the paradox. Their social activity, their social functioning, actually went down.
That's so counterintuitive. You'd think having a dog would force you to get out more.
You would. But think about it. Now you have a very visible sign of your trauma with you at all times. You deal with people trying to pet the dog, asking you invasive questions, restaurants denying you access.
It puts a spotlight on you.
Exactly. The dog might calm you down internally, but it creates all this new external friction. So the lesson isn't that dogs don't work. It's that we need to prepare people for that social burden.
Another trade-off. Okay, the placebo effect. We usually talk about it like it's a bad thing, right? Oh, it's just placebo.
We do, but this review argues we should be harnessing it. The effect size for placebo in depression and anxiety is massive. Sometimes it's almost as big as the active drug.
So the takeaway is that placebo isn't fake.
It's not fake at all. It's the biological effect of hope, of the therapeutic relationship, of just being in treatment. So if a patient feels better after 1 week on an SSRI...
Which is too soon for the drug to be working chemically.
Right. Don't tell them it's just placebo. Bank that win. Use that momentum to start therapy, get them exercising, let the placebo effect give you a running start.
Let's hit vitamin D. The verdict seems to be that it works for depression, but dosage is everything.
It's all about the dose. This meta-analysis found the peak antidepressant effect at around 8,000 IUs a day.
That's really high, way higher than the usual recommendation.
It's very high. And that comes with a big caveat. This is probably only for people who are actually deficient. For someone with normal levels pushing that high-risk kidney stones. So it's not a more is better situation for everyone.
And it didn't help anxiety at all?
Nope. Seems to be a depression-specific effect.
Okay, last one. Metformin for antipsychotic-induced weight gain. This seems like a real practice changer.
It really should be. For years, the model has been start olanzapine, wait for the patient to gain 30 pounds, and then maybe think about adding metformin.
And new guideline says that's way too late.
It's too late. By then, the metabolic damage is done, and it's much harder to reverse. The new recommendation is to be proactive. If you're starting a high-risk drug like olanzapine or clozapine, especially in a younger person, you start the metformin on day 1.
You prevent the problem instead of chasing it.
Exactly.
You know, it all comes back to that central theme, doesn't it? Nuance.
Wow.
Everything we've talked about is about nuance.
It is. It's the nuance of the Brexpiprazole data, the risk calculation for lithium in pregnancy, the social trade-off of a service dog. There's no single right answer.
The right answer depends entirely on the person sitting in front of you, their life, their values, their tolerance for different kinds of risk.
That's modern psychiatry, moving away from this drug for this diagnosis and towards this set of interventions for this individual situation.
And I think it leaves us with a really interesting final thought. We've just discussed heavy pharmaceuticals, vitamins, dogs, and sleep, all as treatments.
Right?
The future seems to be about integrating all of those, not seeing them as separate categories.
Yeah.
What happens when prescribing a dog or prescribing sleep becomes as regulated and evidence-based as prescribing a pill? It's a fascinating question.
It really is. That's the critical thinking we need.
Well, we'll leave it there for this deep dive. As always, keep reading the fine print, and we'll see you next time.
Take care.